Bismillahirrahmanirrahim. Um, Professor Rashid Latif, with your permission, I will start. I'll start by thanking Dr. Aftab and his whole team, Dr. Chima, who invited me over here. I know time is short and lunch is coming very soon. शुरू में मैंने सोचा कि women's session and this male predominance. But as I thought about it, I thought this is a very good thing to happen. Because the family physicians who are male, they also need to be sensitized to the topic of menopause. And a lot of our women colleagues are coming to those doctors, so they need to know what menopause is, how to manage menopause, and what is the role that a family physician can play in creating sensitization, dealing with the issues of menopause and treating menopause as well. So it's a longish outline that I've laid out over here, but I'm going to promise that I will finish within my allocated time, and hopefully 15 minutes should be enough for me. Just want to say that when women undergo menopause, their non-communicable disease risk increases. And non-communicable disease actually is the talk of the town today because women are living much beyond menopause. And that is why it is important to understand that the risk of developing diabetes, hypertension, cancer, mental health conditions, and other cardiovascular diseases also increases. And that is why we should be worried about menopause and thinking about it. Now, what happens at menopause? There are two things that I want to talk about. One is the transition to menopause, and the other is the postmenopausal period. So there are three important areas that I will talk about. First is the vasomotor symptoms, sleep disorders and mood changes, which can start as early as 40 years of age, and they can last as long as 65 years of age. So the vasomotor symptoms are of importance, and they need to be managed appropriately. Urogenital atrophy and dyspareunia will start a couple of years after menopause when the hormone is deficient, and that can continue to increase. So in order to make sure that the woman is able to have a satisfactory sex life, it is important that we are aware of the urogenital symptoms and how to manage them. And the third is that as postmenopausal time and age increases, women are more prone to osteoporosis, things like coronary heart disease, cerebrovascular accidents, atherosclerosis. So this is also something which we need to be working on, that how can we minimize the chances of our women developing these non-communicable conditions. Now the question arises that we all know that women are living longer. We all know that women and families should have an appropriate attitude towards menopause, and the physician's inclinations are extremely important. What is needed is informal education and providing information to the families by the healthcare provider, sensitizing them to their needs, changing our attitude and the attitude of women towards menopause, and making sure that we are able to manage the premenopause and the menopausal conditions. Now, as I said, that there are two important areas of menopause. The first is the premenopausal period, when we ask the women to start preparing for menopause. So this should start as early as 35 years of age, and it consists of a couple of things. Lifestyle modification, you know, has become very important in almost all aspects. But from the point of view of a woman who's going to undergo menopause, and I hope some girls are sitting over here who are around 35 years of age, because this is the time that you should start thinking about menopause transition, your modification of lifestyle, what is the health status that you are in, your mental health, food choices, and understanding the changing needs of menopause. So I'll just rush you through a couple of things. When there is time to anticipate menopause, one should think of not only of our lifestyle, but also of the vasomotor health, bone health, sexual health. And I think this is an important time to start thinking about screening for gynecological cancers. We know cervical cancer is on the rise in Pakistan, and there's a huge campaign for cervical cancer which is taking place all around the world, Pakistan being included in that. So I think we need to look at it. We need to be thinking about breast cancer, endometrial cancer, and so on and so forth. And also to do with mental health, because considering the situation in Pakistan, considering our busy lifestyles, and considering the amount of financial and other pressures that families go through, this is a stressful time. At 35, you're thinking of your families, you're thinking of your own personal lifestyle, not paying attention to your health as one should be doing. Now, the important thing is that when we are talking about screening and early evaluation, we do know that we have screening tests. So we have cervical smear, and now DNA facility is also available. So it should be done every 3 yearly cervical smear alone, and 5 yearly if you're also doing DNA for HPV. Mammography 1 to 2 yearly after the age of 40, depending on the risk factors, and DEXA scan every 2 years in the postmenopausal age group. In addition to that, the waist circumference, blood pressure, weight, BMI, self-examination of the breast, and an annual pelvic examination are of importance, and one should be thinking about them. This is a concept we initiated in India, and they have created Club 35. And Club 35 is basically a club for ladies who are 35 and beyond, in which we talk about lifestyle modification, talk about adequate physical activity, regular exercise, balanced diet, and calcium and vitamin D supplementation. So we keep on talking about food choices, but we rarely realize that the women actually start developing a passion for desserts and for all those mithas which are actually banned at the time of menopause. So more changes regarding food in terms of fruit and vegetables, whole grains, iron, soy, and flaxseed are what is recommended in addition to taking an adequate amount of water. And all those things that we love, which are the spicy foods, caffeine, and sugar, we have to curtail them. How are we going to do it? That is our challenge, and that is the challenge which we need to fulfill. Now, in comes menopause. So women who are prepared for menopause and whose healthcare providers and family physicians are smart enough to prepare them for menopause will have lesser challenges. But those women who are presenting to you for the first time after menopause, your challenge and their challenge is quite a bit. We all know that the Women Health Initiative results which were propagated all over the world showed that women are probably at risk of malignancy, especially of the breast post-menopause if they are on hormone replacement therapy. So I think one of the main things that we need to do about menopause is break those myths and misconceptions which prevail around menopause. So it is not true that we need to stop prescribing hormone replacement therapy because fear of breast cancer, and I'm going to talk about it in a little bit detail. Now, when we talk about managing menopause, in addition to all those things that I've mentioned previously, we need to be looking at what are the choices that we can give our women. So we can provide cognitive behavioral therapy, which is difficult to get in Pakistan because enough people are not doing and working on it. The other is hormone replacement, and the third one is the non-hormone replacement therapy. So I'll touch them just a little bit one by one. When we talk about cognitive behavior therapy, it is basically an intervention for improving the mental health of the women. And the psychologists have to play their role in propagating this cognitive behavior therapy and helping to change the way that the women think and behave, especially dealing with the anxiety disorders, the incidence of which is going to increase after menopause. Now, the kingpin of it all, the hormone replacement therapy, which scares us to death, most of us. The important thing to understand is that hormone replacement therapy has got a lot of benefits. The benefits are in terms of decreasing the urogenital symptoms, improving the vasomotor symptoms, preserving bone density, improving the joint and muscle pains, improving mood swings, sleep disturbances. These are all things which can be improved if the woman is on hormone replacement therapy. So also you can improve the quality of life and the sexual function for that woman. Now the question is that when we talk about hormone replacement therapy, we have to include the lifestyle modification as a part of the overall hormone therapy that we are talking about. Now the question is, do we give it to all? Or whom do we give it to? Who are the women who are appropriate candidates for hormone replacement therapy? And if we pick on the low-hanging fruit, we are going to be better off while dealing with these patients. So the simple thing is, you don't give it to the asymptomatic women, but you give it to the women who need it. Women who have got premature ovarian failure or POIs, women who have got vasomotor symptoms, genitourinary syndrome, osteopenia and osteoporosis and are at risk. And the good thing is that the risk scores are available all over. Actually, they are available online, in which you can put the basic information and you can calculate the risk score for cardiac disease, risk score for the bone disease, and so on and so forth. And after removal of the uterus, and especially if the ovaries have also been removed. And one has to be very careful in removing the ovaries because we do not want to remove ovaries prematurely, because that is going to affect the status of the women. So when we are prescribing hormone replacement therapy, we have to look at the benefits and the risks of hormone replacement therapy. And obviously, we have to choose a good balance of treatment that we want to give, which does not increase the risk, but helps improving the benefit to our women. This is a long statement and a couple of long statements, but just to summarize the long statement in a couple of lines, the thing about hormone replacement therapy is the fear of breast cancer. And I would just like to take you through the last 2 lines in which the International Menopause Society says that the increased risk estimations are only less than 0.1% per year of use. So the incidence of breast cancer related to hormone replacement therapy is pretty low. The second information that I want to give you is that it is not the estrogen which is responsible for breast cancer, it is the type of progesterone that you use. So dydrogesterone may be associated with lowering the risk of breast cancer. So use safer progestrogens for the women in whom you are prescribing hormone replacement therapy. The Journal of American Medical Association actually published a study because people think that hormone replacement therapy will kill us. So they did a study and they took out records of 27,000 women who took hormone replacement therapy or a placebo for a period of 18 years. And what was the result that they came out with? The result was that out of the total women who died, half of them were on hormone replacement therapy and half were not. Just proving that hormone replacement therapy is not going to increase your risk of dying because of the medication that you are taking. Now, I'm coming just to the last couple of slides of my presentation. There are certain principles of hormone replacement therapy, and I think that the most important principle is that you have to tailor the treatment according to the need of the woman, and it has to be individualized. Unless you individualize your management, you will not get an appropriate treatment plan for the woman. So when you are making your treatment plan, you have to consider her personal, her family history, her choices, and her health status. I think that is the most important piece of information that I can give you. The second most important piece of information is that women who have got a menopause before the age of 45 actually should be put on hormone replacement therapy till the natural age of menopause, which in Pakistan is 51 years of age. So anybody who comes to you with menopause before the age of 45 needs to be on hormone replacement therapy, and you should not be worried about it. This is an international recommendation which you can follow easily. The other message is that counseling should convey the benefit and risk of hormone therapy in a fashion that is understandable to the patient and not scaring the patient in any manner. Data from various trials has supported and shown that if the woman is under 60 years of age when you are starting hormone replacement therapy, it can safely be given for a period of 5 years. And that is a good amount of time that if you put the woman on hormone replacement therapy for 5 years, this is pretty good, but you have to call back the woman at least for an annual consultation. Initially, I think it should be 6 months, and then later on, you should call them after every year. Now, I'm not going to go into these details, but just wanting to tell you that the choice of hormone replacement therapy actually depends on whether the uterus is intact and whether the ovaries are in place or not. So if the ovaries have also been removed, then it is actually very simple that you have to give estrogen. If the uterus is intact, then an appropriate medication has to be chosen. So we have to take a detailed history, calculate the risk, counsel the patient, and then look at the available choices and the cost of those choices. So this is a list which is a longish list, but it is showing you the cost of treatment, what is available, and the first two, the ones which I have mentioned, are basically the ones which can be given to women if there is no uterus. But if the uterus is present, then Clymin, Famoston are actually good choices for the women. If you look at non-hormonal replacement therapy, and people are very scared of giving non-hormonal replacement therapy, it is a wonderful drug for vasomotor symptoms of the women. Achha? Okay, time here. So this is an important drug for the women who are suffering from vasomotor symptoms. And these are also available in Pakistan and can be used with ease. If you are worried about the dose, you can start with the smallest possible dose and then see what are the needs of the women. This is the therapy for bone health, and obviously these have to be given to the patients who are in need of hormone replacement therapy in terms of the protection of the bones. The choices are many: Ivista, Fosfomax, Ruventa, Bonviva. They are all there for us to follow if we want to. Now I will just stop with my last 3 slides, and I've got 2 take-home messages, and one is an important message for the family physicians. The take-home message is that we have to individualize the risk of every woman. We have to look at their family history. The timing or the window of opportunity is important, because if you start early, give it for 5 years, you are reasonably safe and you will get all the estrogenic benefits. Patient selection should be appropriate, and we should not generalize management. We have to tailor the dose according to the requirement of the patient. HRT is still the most effective therapy for vasomotor symptoms, but we have to make sure that the therapy does not affect the heart, the thromboembolic phenomena. We have to look into the lipid profile, but it has benefit for the heart bone. Use of the lowest effective dose for the shortest period of time is good, and dydrogesterone is the most suitable progestogen. Now coming to my last slide, and this is actually my message for my colleagues, my friends, my senior family physicians. I think it is our responsibility as family physicians to make sure that we inform and discuss with the women preparing for menopause, because we have to make sure that the young female population, when they're coming to you, they understand what they're going to go through in the next 10 to 15 years, and they should be prepared for that. My second message is, you must ask the women who are going through menopause about any symptoms related to it and address them as much as possible. And my third message is, it is a collaborative world. So if there is anything in which there is uncertainty, I think it will be a good opportunity to refer the patient to an appropriate person so that hormone replacement therapy can be prescribed to these women. With this, I would like to thank you. And my message is that menopause matters. Thank you very much.